Okay, we good?
We're good.
All right. Hi, everyone. So happy you could join us. You're probably not happy about the topic, but always good to talk to people out in the field. Let's kind of review what's going on here. I think, as many of you know, that CMS has proposed a new rule, and that's basically why we're here, because the rule does affect your meaningful use in 2014. And to be honest with you, and I don't think CMS is trying to downplay this, the reason the rule has been proposed is because so many people are having difficulty in meeting timelines for 2014 attestation. So let's kind of review where we are, what the rule does and does not say, and then what next steps are. To begin with, the rule was officially published in the Federal Register I want to say last Friday, I guess it's 2 Fridays ago now, May 23rd. And that is always the publication in the Federal Register is the date at which official actions on the rule are measured from. So from that May 23rd date, CMS has to allow, under the federal rules of administrative law, has to allow 60 days for comments, and then another 30 days to compile those, respond to those comments, and to make changes in the proposed rule. Well, as you can tell, 60 days takes us to the end of July. Another 30 days takes us well into August. And even if they would be able to respond more quickly than a month, the fact of the matter is we are looking well into the time period when the hospitals would be completing their last possible attestation date. This is where the whole problem arises around what is going on. Let me just tell you, we have officially commented about the rule for much of Ohio, in the sense that we have raised issues that were raised to us in the field, not identifying any hospitals, any practices, any vendors by name, but rather just talking about workflow issues, issues of timing, and et cetera. If you too would like to respond, here's the information on how to respond. And I would encourage you, if you're struggling on your 2014 attestation, to make a point of responding. CMS has reached out to us as many as 5 times and asked to make sure that we as an organization and organizations like us around the country were responding, but also to encourage hospitals and practices to send in their stories, because we all know that there are a ton of workflow issues around adoption of 2014 certified systems. So if you would like to comment, feel free. You need to get those comments in by July 23rd. Let's look at how, before we go into the specifics of the proposed rule, let's look at how it has been received nationally, because I think that gives you an idea of the pulse of the healthcare world when looking at adopting this rule. First of all, the American Medical Association, AMA, has been the most outspoken and the most detailed in their comments. The AMA has made no bones about the fact that they have long considered the Meaningful Use Program as being too rigid and its timelines too structured. What the AMA specifically is proposing in response to this rule is that rather than an all-or-nothing approach to meaningful use, that if a hospital or an EP would meet 75% of the measures, that that would be deemed as passing meaningful use and make you eligible for your incentive payments. The companion piece to that is that if you pass at least 50% of the measures, that you would not be penalized financially for not having met more of the measures. So this is what the AMA has proposed as their main points. Some of the other things, the talking points that they would like to see, is to see core and menu blended together, streamlining of the meaningful use measures, because as we all know, the fact that it's listed as one measure does not mean that it's one measure. It may be as many as 3 or sometimes 4 measures built into one what's called core menu measure. They would really like to see CMS remove those measures that rely on someone other than the hospital or physician taking action. Specifically, those areas would be the 5% required for patient portal for view, download, and transmit, and the 5% on the physician side, on the EP side of secure messaging. They have, and I can remember this when the Stage 2 rules first came out, that has been a refrain of AMAs now for a couple of years, that no measure should rely on somebody else meeting their workflow. They'd like more effort in the quality programs and would like the mandates being evidence-based. So these are the main positions of the AMA. As I said, they are just positions. They are comments that the AMA has made to the proposed rule. In the other big organizations that have commented, shall we say tentatively, the American Hospital Association has probably been as notable in the fact that it has not made extensive comment as in the fact that it has not taken a position opposed. I am assuming that that is because the AHA has been negotiating behind the scenes on how this is going to work for hospitals. They have commented publicly that they do feel that the proposed rule, they support the flexibility that is built into the proposed rule. They raised the issue of hospital deadlines, but the CHIME, the healthcare information management execs, were much more pointed in their comments about the fact that the timing of the proposed rule is really problematic for hospitals, because if the rule does not become final until 30 days after you begin your reporting period, it's going to be hard to know what measures you're going to report on. So with that in mind, we can look at the rule and then discuss strategies around possible adoption of it. Okay, here are the areas that CMS is proposing, and I do have 3 slides that are specific to quotes within the rule. And the reason we did that is I think it's very important that people see what the actual language of the rule is so that you understand the limitations upon which CMS had created this proposed rule and how it would work. First of all, the addition of certified EHR technology which is available to provider dictates the stage and version of meaningful use objectives and measures to which the provider will be able to attest. Key points there are you need to attest to the highest level of measure possible. So if you would normally in 2014, you assume what your normal reporting stage and year would be for 2014. Say you're stage 1, year 2, that you should still be striving to meet that stage 1, year 2, and it's only if you have technical issues or vendor issues relating to that that you'd even look at the fallback position. Same thing if you're moving into stage 2, which has a lot more interoperability issues. You're still going to be expected to try to meet that measure and only use this rule if in fact you are not able to. So let's look at some of the other limiting language in it. First of all, apologize for the length of this, but again, I think it's important that you hear exactly what CMS is saying. A provider's ability to fully implement all the functionality of 2014 CERT may be limited by the availability and timing of product installation, deployment of new processes and workflow, and employee training. So those are 3 areas that they're recognizing may be a problem. Therefore, providers who are scheduled to begin stage 2 for 2014 reporting period, but are unable to fully implement all functions required for stage 2 due to delays in 2014 availability of certified system, would have the option of using either 2014 to attest to stage 1 measures for 2014 for the 2014 reporting period. So basically what CMS is saying here is that if you are trying to adapt your workflow to meet stage 2 measures, that there are areas in the rule that would allow you to address problems that you're having, workflow or vendor or training that would give you basically the ability to attest to a not as high a measure standard, so not a stage 2. The third thing, and those of you that I've worked with know how important and how much we stress to you the need to consider the audit concerns that arise around attestation for meaningful use. So I think it's important that we look at what you are basically going to attest to and basically put your signature to if you move back to one of these other lower measures. Providers who choose this reporting option, so whichever fallback position you might take, must attest that they are unable to fully implement 2014 edition CERT because of issues related to 2014 edition availability delays when they attest to the meaningful use objectives and measures. So what does this mean? What this means is, as you consider what you should be doing in 2014, one thing that I would keep in mind is if you really do need to fall back to another stage, if you have to move back to stage 1 or an earlier year stage 2, please make sure that you have documented correctly the issues you were having, be this vendor letters, vendor emails, certification date, receipt of upgrades, issues with training. To me, at least as the rule has been proposed, it's not a walk in the park. It's not saying, hey, we're having issues, we're just going to go ahead and attest to stage 1 rather than stage 2. It is saying you must document what your problems are. And that is, I know one comment that we made to the rules was raising the issue of what type of audit trail needed to be created, and that maybe it should not be quite as significant as CMS is proposing here. Okay, let's let me move on here. Okay, there we go. All right, let's talk about what is actually in the rule. What is actually in the rule? There is a look back category created for both stage 1 and stage 2 that looks back to the 2013 measures, and we'll look at the chart in just a minute that specifically states what measures you can attest to. But just so you understand, the whole premise of the rule is if you're having problems in 2014 due to vendor issues or training or whatever, that you should be able to test at an earlier version that you might already have met. The rule changes the requirement that you must have, as you know, we were all requiring, knowing that CMS required in 2014 in order to attest to meaningful use, all hospitals and EPs had to have 2014 certified technology. This rule changes that requirement. It allows you to attest with, depending on the situation, either 2011 certified version, a combination of 2011 and 2014 certified version, or 2014 certified version. So there's 3 options here that this rule recognizes in place of the just 2014 attestation that was required prior. And the last big thing it does, this is no surprise, this has been talked about actually when Farzad was still the director of ONC. He had done a press release on this, and it's now being made official that Stage 2 would extend for an additional year, so that Stage 2 would now be 2014, 2015, 2016, and Stage 3 would not begin until 2017. As important as what the rule does say is what it does not say, and this, I really want you to focus in on this. The rule does not extend your reporting period, nor does it remove your penalties, and nor does it protect your incentives. So what's being proposed here by CMS is basically you still need to attest in 2014 if you, A, want to get your incentives in your testing to Medicare, which almost all the hospitals do except for children's, or if you're an EP and you're attesting to Medicare, you still need to attest in 2014 if you do not want to lose your incentive. The other side of that is you need to attest if you want to avoid the penalties that are going to incur in either 2015 or 2016 if you do not attest. And the only way to avoid the penalty if you do not attest, either under this rule or under regular guidelines, is if you file for a hardship exception. So if you are planning not to attest, you have to have that hardship exception in place and have it granted in order to avoid the penalty. So under this rule, it's going to be the same as it's always been. Hospitals have to begin their attestation period July 1st for 2014 attestations. Physicians and other EPs would have to begin their attestation period no later than October 1st of 2014 to draw down 2014 incentives if there is no further change in this rule. One just minor note, this really isn't going to affect the hospitals because we have 97% of the hospitals have already filed for Medicaid incentives. But on the EP side, if you're just beginning a provider and you want to work them through the Medicaid incentive system, and you are not planning to attest to meaningful use the first year, but you are planning to try to get the AIU, the Adopt, Implement, or Upgrade first year funds, you will have to show that your technology is that you have purchased 2014 certified technology. Whether or not you've fully implemented it or not, you have to show that your contract is for 2014 certified technology. All right, let's look at the chart that CMS has proposed as to how this attestation is going to occur. If, in fact, you are supposed to be at Stage 1, Year 2, and I suppose you could be at Stage 1, Year 1 also if you're just beginning your attestation period, you would basically, if you have not received your certified upgrade, you would be attesting to 2013 Stage 1 measures. If you have received an upgrade, in this second column, this combined 2011-2014 certification is mainly for hospitals. That first column is going to be, could be hospitals, could be physicians. It's usually EPs that have that fully certified system that may have not received or their vendor may not have been certified yet. We'll be looking at the 2011 certified timeline. For hospitals where you are relying on a lot of different modules to meet meaningful use, this middle column, this question of using both 2011 and 2014 certified systems is where a lot of you are going to end up. We are dealing with a lot of hospitals in Ohio that for the most part have their primary system is 2014 certified, and it may not be fully deployed yet, but they do have, the underlying system is certified. However, because of their modular approach to getting the job done, they may have one module or more than one, but usually just the one, that it can maybe a smaller vendor that just has not gotten that certified system finalized. And so if this is the case, if you're working with a blend of 2011 and 2014, then basically you have more of an option of how you're going to report. And this is really going to be based upon the functionality that is provided by those modularly certified systems. You can report to 2013 Stage 1 measures, which basically is no patient portal, no increased CQM, or you can report to 2014 Stage 1 measures, which would include patient portal and increased CQM. If you're at Stage 2 in 2014 and you're presented with that same issue of, your modular and not every single module is certified, you actually have three options. You can do 2013 Stage 1, 2014 Stage 1, or full Stage 2 measures. So again, it becomes a functionality issue, what the system is able to do, what your workflow and your adoption has been able to meet. The third area is if you are fully 2014 certified. And this, to me, gets into more of a problem area for certification, because if you're a fully 2014 certified system, either complete or modular, but you have everything, all the checks in place for a certified system, then you're more limited in how you can use this rule, in the sense that 2014 Stage 1 measure is your fallback position for if you're in Stage 1. So basically you have to use the Stage 1 2014 measures. If you're in Stage 2, you can either use 2014 Stage 1 or full Stage 2 measures. What is the significance of this last column, and why do I say this is a problem? If your problem in adoption has to do with patient portal issues, which many of you do, I think you realize that it is a lot more in-depth. There are a lot more issues involved around patient portal than just turning on the button and getting the patient's email address. If that's where you're hung up and you're 2014 certified, you do not have the option of not having the patient portal as one of your measures. So if you're actually, in this case, you're better off if you have a module that's not fully certified and you fall in that middle column than if you have a module that and you're completely 2014 certified. You are going to have to report on patient portal. All right, let's see some of the other issues here. This is, again, the Stage 1, where you've got 2013 or 2014 Stage 1 if it's a combined system. But let's look at the clinical quality measures attached to that. Recognize that in any of these potential changes, because as we know, for both hospitals and EPs, the clinical quality measure reporting is really bumped up in 2014. Real emphasis on 2014 quality metrics and how this is going to lay the groundwork for 2016 reimbursement reform. So you want to be paying attention to how you're reporting this, depending on how you're reporting your measures. And it really gets linked. You are basically first going to be deciding what set of measures you are going to attest to, and then look and see the corresponding CQMs for those measures. So if you end up reporting and you're doing the look back to the 2013 measures, then you are going to be doing 2013 CQMs. Practically speaking, what this means is for the hospitals, you will be reporting on the 15 required CQMs that you had in last year when you attested. And those are all predetermined. For the EPs, you will have the 6 measures that you reported on in 2013, 3 of those being the required ones, smoking, vital signs, and I'm sorry, I'm drawing a blank on the third, but the three required and then the 3 optional. And so you're going to go back with that scenario where you are reporting based on the 6. If in fact you move ahead and you do end up using 2014 measures, the hospitals will be reporting on the 16 measures, and the physicians and EPs will have to report on 9 measures. So keep that in mind when you're thinking about how you are going to test this year. Do a side-by-side where you have your meaningful use measures laid out, both your core and your menu, and then you make a third column that talks about the CQM reporting. Okay, we've covered all of these. What I want to say, and then we'll open it up for questions because it's really much more meaningful to you all to hear what your compatriots have to say about things. The bottom line here is this is not a final rule. It is not a final rule. We don't know what the final rule is going to look like. I think it would be fair to say that the standards will not be any less than are being proposed, but it may be more. Whether or not CMS decides to, quote, protect 2014 incentives and allow you to skip a year is something we'll just have to wait and see. But for right now, as I would say, assume that this is the base and there may be other changes. But the real bottom line here is you need to stay the course here on what you're working on right now as far as your measures and your CQMs. You are going to be expected, and as I said, unless we have more guidance on the audit front, I'm thinking you're going to have a little explanation about why you're not reporting at the prescribed level if you are not able to. So what I'd like to suggest that everyone do is take the measures that you were already working towards for 2014 attestation, continue to try to do the build, the education, the training. Clearly you're going to be limited if your vendor has not given you your upgrade, has not delivered the patient portal. That's limitations you don't have control over. But once you get out of that area and assuming that you have all functionality present and you're just really struggling to get the workflow behind it done, I would continue to try to work towards those 2014 measures and only consider Plan B if you're going to try for one of the look-back areas as the fallback, because at this point, as I think we all are aware, especially with the hospital reporting, the 2014 certified upgrade reporting is not equivalent to the 2013 certified system or the 2011 certified system that was used in 2013. And this, I think, is going to be one of the problems. So I guess what I'm saying is try not to create more technical issues for yourself. If you think that you can attest to 2014 standards with your 2014 certified system, continue to go down that path and only use this rule as backup if in fact you're having vendor issues and you just don't think you're going to be able to make it. So that's where we are. What I would say is really keep paying attention to the information either that we provide or that comes directly from CMS or from HIMSS or any of the other groups you're attached to see if there's any sudden changes in this proposal. But basically at this point in time, this is being offered to you as information about what's being proposed and not as a final solution. So with that, I'm going to open it for questions, and let's see if we can get some answers for you. Hold on, Dottie's opening the questions. Let me see what's going on here.
And I also wanted to say that Kathy and I will be emailing you with the PowerPoint itself. We will be sending you the hardship exemption. I'll be sending you some materials on meaningful use stage 1 and 2 that really are checklists.
Yeah.
I'm trying to think what else, Kath.
Okay. Yeah, we'll send you everything that we have on information that'll support you no matter what you try to do. But, you know, the biggest thing is to try to figure out your strategy and then move ahead with that. Okay, let's look at our
Let's try and go up here.
FAQs. Hold on a second. We've got quite a few coming in, so let me make sure that we're starting at the top.
I think we're
at the top. Okay. Do I understand correctly that this is only for Medicare meaningful use and not for Medicaid meaningful use? At this point in time, this is only Medicare. But with that being said, I reached out to Medicaid as soon as the rule was published and asked them what their position was, because clearly it's not going to affect the hospitals so much because they're a dual, as I said, unless they're children's hospitals, they do dual reporting of meaningful use, and so that controls their Medicare. But certainly on the EP side, it's a huge issue if you've got some providers that are Medicaid and some that are Medicare. You're going to want to know what measures to report on. What Medicaid told me is they were waiting for the final rule, which, as I said, was published May 23rd, and they're making an internal policy decision to decide if they're going to adopt that same strategy for Medicaid. They have not indicated such yet. I don't know if they're going to wait for the final rule or if they're going to put out interim guidance, but so that's a kind of to be continued discussion. Okay, second question. How will the rule affecting new providers who can attest on 2014 technology? I thought there was a requirement that they attest first quarter. Will this allow us to attest in the last quarter? Can we still use the 2013 measures? Okay, let's talk about reporting periods, because that's, as I said, that's something that the rule does not change. So if you are a hospital and you've attested once, then you are going to be reporting by quarter. So clearly, if you're not in a reporting period right now, your only option is to begin July 1st of 2014, and you'd report July, August, and September. If you are an EP and you have already attested once or more, then you too will be reporting by quarter if you're Medicare. And so on the physician EP side, your next two options are to start July 1st or to start October 1st. And that is if you're doing Medicare and if you've attested at least once. If you are doing Medicaid or it is the first year of attestation, you can attest to any 90-day period. So Medicaid or first year Medicare can do any 90-day attestation. So that's the difference here. These quarterly timelines are related strictly to Medicare. The question about when you have to begin, if you've done, if you've not attested before and you're trying to avoid the penalties and you're an EP attesting to Medicare, then you need to begin your attestation period by July 1st. The reason why is that CMS will close the clock on October 1st on deciding penalties for 2015 for anyone who has not attested. So that's your limiting factor. Other than that, EPs can begin as late as October 1st to attest to Medicare and still meet all the 2014 requirements.
She's giving us some information. Angel Wilson, new provider to a Group 1 charity, HR.
Okay, well, yeah, the new provider, it's, I assume what you're asking is if they're at a different stage. And you would be, if they have not attested before, you'd be back on stage 1. So we can talk about that. You can either email me or we can discuss it. Let me look at the next one. Let's see. If reporting meaningful use year 1 or stage 1, year 2, this fiscal year, will the attestation method be the same as it was in 2013? This depends on whether or not you have received all your 2014 certified technology. if you've received all your 2014 certified technology, Ron, I don't know if you're a hospital or a physician office. Send me a little note on what you are so I can comment it. Hold on, I don't think Ron. Oh.
EH.
Okay, so you are
Hospital.
a hospital. Okay, if you're hospital, stage 1, year 2, this depends on whether you've received all your 2014 certification. So remember what I was saying, if you're in a situation where you're modular and not everything has received certification yet, or you haven't, it hasn't been deployed to you, then you can attest to that fallback of the 2013 stage 1 standards. However, if you have received and your system is fully 2014 certified, then you do not have that option of the look back to the 2013 standards, and you would have to, which would be the pre-patient portal, and you would have to attest to 2014 standards. I know it's confusing. I know it is. Look at the slides when you get them. As I said, this is one of the areas of, I won't say controversy, but questions over this look back, is that whether if you have a fully certified system but it's not fully deployed, whether or not that allows you to flow back to the 2013 standards. Okay, maybe this question was answered. My practice did stage 1 90 days in 2012, 365 days.
Stage 1 20.
And I assume that's 2013 and not 2014. You did 365. Our software is not yet certified for stage 2. If the rule passes and we're able to repeat stage 1, is it only a 90-day reporting requirement? Yes. Everyone in 2014, and this rule does not change that, the reporting period is either 90 days or by quarter. By quarter if you're doing Medicare, 90 days if you're doing Medicaid. So even if you're in, say, your EHR system does not become certified before you report this year, which, believe me, I know several vendors where that's the case, you clearly are one of the people that they're trying to reach by this rule. And that in that case, you would take your 2011 certified version and use it to attest to the same standards you did in 2012 and 2013. And you would be attesting for a 90-day or quarterly reporting period. If you're Medicare, your options would be start July 1st or start October 1st. Okay, let's see what the next question.
See, Ron is just telling you that his
vendors, oh, okay. Hey, Ron, if your vendor is not yet 2014 certified, and if you're modular, I mean, if you're not 2014 certified, then you're definitely going to use the 2013 standards, which means pre-patient portal. If it's combined module or modular certification, and you just don't have some of the certification in place, then you have the option of whether you're doing 2013 or 2014. But it sounds to me like your primary system is not 2014 certified, in which case you do fall back to 2013 standards. Okay, let's see. If I have a 2014 certified version, does the proposed rule allow me to use stage 1 measures, in effect removing the requirement for patient portal? Jenny, this is, to me, one of the problems with this rule. It does not, at least not as it's been proposed, does it say if you have a fully certified 2014 certified system that you do not have that look back option to go with pre-portal standards. I personally feel that this is going to be one of the most discussed areas and areas of revision for the rule, because what we've seen in the field is a whole lot more issues related to patient portal. Actually, I shouldn't say more than anything else, but I would say more widespread than anything else. And part of the issues are that if you have a fully 2014 certified version, but the portal hasn't been deployed, which is true time and time again with the vendors, that it's going to be impossible for you to report on 2014 standards. So right now your answer is yes, you do have to use 2014 standards if you're fully 2014 certified, which includes patient portal, but let's see how that looks in the final rule. Okay, let's see. We are when is the final rule expected from CMS? The final rule, okay, the comment period closes July 23rd, and CMS has up to a month to respond to the rule. My personal feeling is because they've been so anxious to get comments in prior to that, I'm sure they're working on redrafting already, but the earliest you could expect some final copy is beginning of August. The latest would be August 23rd. So EPs, that should help you a bit. Hospitals, that's not going to be quite as helpful because you won't know what your game plan is when you're in the middle of reporting. So let's see. Yeah, Q&As we're sending out to everyone. We actually, this is our third webinar on this. We're doing our last one tomorrow, and Dottie's been really good about transcribing all the questions and answers that have been sent in, and we'll send that as one master document because there's been a lot of good questions, a lot of good fact patterns. So watch for that. We'll send you all the slides in the handouts today as soon as we get done, but the FAQs will wait until after tomorrow's webinar, and we'll just finish combining those. So you should have them by the end of the week, I would think. Okay, would you be able to present a separate session regarding hardship? Yeah, we could definitely do hardship. I'm trying to think of, probably we do. I was trying to think if there was enough meat to do a whole session on hardship. We could probably do a good half an hour anyway, because the hardship exception, for those of you that haven't fortunately had to use it yet, it's very explicit. It's, it's not like, hey, give me a hardship because I'm having vendor issues. Very specific, the areas that you have to cover for hardship. I don't know how much proof we're going to have to show in the hardship area, and basically how it's handled. And if you're doing it for a group, which you can do, you can request a hardship for a whole group of practitioners, or you can do a hardship just for one. So maybe what we'll do is plan on that for next week, because for those of you that may have to use that to avoid penalties, you will have to do that by July 1st.
And I do have a fact sheet on that, Kat.
Yeah, and we'll send out the fact sheet, but if you all are interested, we can certainly do a quick and dirty on the hardships. Okay, do we have anything else? Has anything else come in?
I'm not seeing anything.
Okay, if we don't have any other questions, what we'll do is just get this all out to you, and then just, stay in touch with Dottie's newsletter, and we'll keep you posted literally as the stuff comes in the door. And probably what we'll do is keep your emails that participated in the webinar in a separate category and make sure that you directly receive information on the rule updates as we get it, as opposed to just relying on the newsletter. So we'll do everything we can to keep you abreast of it, but what I'd say is please, continue to work as well as you can with the certification technology that you have, and with your workflow, and with your training, because it is going to be a process no matter if you're linked to stage 1 or stage 2. And for the hospitals, you know that no matter what you do in 2014, you're going to have to start your reporting period October 1st for 2015. So you're not buying a lot of time no matter what you do in 2014. Okay, and with that, I thank you all for your attention, and we'll be in touch. Have a good one.